by the clavicle side. Yes, the clavicle.
Okay.
Then by the ribs.
The magnification. The heart would be slightly magnified on anterior posterior.
Anterior posterior.
Anterior posterior. So the heart might be magnified on the anterior posterior images. Also on anterior posterior images there is much more of a shadow of scapula superimposing the lung fields. As on the posterior anterior images, the patient stands with like heart hugging the detector, and scapula are moved laterally, freeing the lung fields. And lastly, there is almost always marking of whether the image is anterior posterior or posterior anterior on the images. Now, the key areas, what you should look for on frontal chest x-rays. First of all, hemidiaphragms and costophrenic angles. In normal, hemidiaphragms have dome shape and the costophrenic sulcus is sharp. The hemidiaphragms can be flattened in case of hyperinflate lungs due to COPDs. And the angles can be blunted in cases of pleural effusion. And the second one is mediastinum, lungs, bones, and soft tissue. So look at everything. On the right, classically, you might see the right paratracheal stripe. So on the right, you should see the right paratracheal stripe, and this little bulge is the superior vena cava. And inferiorly to it, we will see the right heart border. On the left, you will see the aortic arch, the main pulmonary artery obfuscation, and left heart border, which is left ventricle. On the right, which part of the heart is visualized? Atrium. Right atrium. Why not right ventricle?
Question is not there. Can you repeat question?
Yeah. Why is the right heart border the border of the right atrium and not right ventricle?
Because ventricle is right.
Where is the right ventricle?
On the downside and base. Yes.
So when you see the heart slightly magnified, not slightly, when you see cardiomegaly from the right side, what would you think? Which part of the heart is dilated?
Ventricles.
Why? If the right border is slightly enlarged, why is it due to the ventricular enlargement and not atrial? You cannot tell which part of the heart is enlarged only by frontal chest x-rays, because you see just the total image, overall image, and you cannot evaluate which part is enlarged. So this is the schematic view of the heart and heart shadows. So you can see superior vena cava, inferior vena cava, the right atrium, right ventricle, then from the right ventricle we have
pulmonary stream. Right pulmonary artery left.
arteries, then we have the, what is this?
Which one? Coronary artery.
Left atrium, stage 4, pulmonary,
Arteries.
and then we have
Ventricle, left ventricle.
ventricle, and
Aortic arch.
aortic arch, and descending.
Descending.
And this is the overall image. And on lateral chest x-rays, you should look, we have already talked about it, you should look at retrosternal space, it should be clear, and you should look also at the thoracic vertebra, becoming blacker when you go from the top to bottom, and also look at the costophrenic ankles. Why do we see the outline of the mediastinum? Because of the differences of densities. Because the mediastinum is soft tissue mostly, and surrounding it we have two lungs, which are air-filled, and those appear as black bar densities on X-rays. So it's the same with the same reason as you can see white letters on the black background. So because it has aerated lung next to it, and there is density difference. So this is a kind of picture of blood vessels. And in the second image, we have some opacity in the airspace. So here you can see in the third image that, what is this called? When you see the bronchus.
Hilum?
When you see the bronchus due to surrounding consolidation.
You do know that.
On normal chest X-rays, you do not see the bronchus
Oh, that
itself.
air broncho.
Air
Air
broncho.
broncho.
So the consolidation, what is consolidation? It's when the air in the airways are
Mhm.
displaced with fluid, blood, pus, and the radiologist can't really tell if it's blood or pus or fluid or protein, only by X-rays. You can consume what type of fluid is it on CT scans and on MRIs, but not on X-rays, because on X-rays, fluid has the same density. You cannot differentiate whether it is blood or just simple fluid. Skip this one. So the first case is a patient who has cough and fever. What are the findings and what is the diagnosis?
On the left side we are seeing the fluid on the other. Left side we are seeing the fluid on the other side.
Fluid?
Hmm?
Okay. Where? Try to describe first of all the image findings, then go ahead with the diagnosis. Increased density or decreased density? Ossification or lucency? Right or left?
On the left side we are seeing
On the left
ossification.
side, ossification, okay. Now, which lobe or zone is affected?
Down side, lower lobe,
Why lobe?
because that you so say that upper the both diaphragm
Can you
means
see the diaphragm? No?
that in that picture you can see.
Here we can see. This is the left one.
Yes.
This is the right one.
Yes, so it is preserved so lower.
Is it lower part of the lung or upper or mid?
We are seeing this
When you see the
lower
order of the
diaphragm,
diaphragm, it is not lower.
lower lobe, middle lobe, middle lobe,
And which lobe is affected?
middle lobe. No, but
On the left side, do we have
no. Upper.
That is upper lobe. Here we have upper lobe consolidation. How else can we differentiate whether it is upper or lower lobe? Similar sign with the
By
diaphragm.
Fisher. By Fisher.
You cannot see Fisher here. sure you can tell that there is no cingulate sign with hemidiaphragm. Where do you see cingulate sign? With which structure?
By heart.
Left heart border. The left heart border is cingulated by the consolidation, and it is upper lobe. And when the hemidiaphragm is, it is the lower lobe. So here we see what other findings can you see?
These are bronchus. But we are seeing this bronchus.
That is
Here bronchus.
the diagnosis is
Pneumonia.
which part? Left upper lobe
I see.
pneumonia.
That was just guess, ma'am.
This is the
Upper left.
pneumonia.
Lobe of pneumonia.
This is the follow-up chest X-ray. You
After
can see
that.
that everything is resolved and the patient is going well enough. Second case, the patient again has cough, fever, the findings and diagnosis.
On the right side. Can you zoom this feature?
Frontal lobe.
This one, front. So again, air bronchogram is present because of this.
Which side?
On the right side.
Right side. Consolidation or lucency?
Lucency. No, consolidation.
Consolidation.
Can you take that picture left side now? Diagram. We have to tell lobe also, no?
Why? Okay, lobes on which lobe?
Can you take that left side diagram levels?
You want to see which lobe?
It is full.
Where is the consolidation here?
And there is also that ground circle, that spherical opacity.
This one?
Yes. It
That
is.
is the high lobe.
Left one. Yes.
Which lobe is it?
It's full circle of diagram, so middle lobe.
This is right middle lobe pneumonia. What else can you see?
What else?
Can you see the fissure? Horizontal fissure.
On the right side, no.
No?
This one?
This one.
Yes.
Is everything okay with the upper lobe?
It's same on the left side also.
This part the same with the right side. There is again small consolidation.
So upper middle. Okay.
That is right middle lobe pneumonia, but the right upper lobe anterior segment is also consolidated. Another case, we have again cough, fever, findings and diagnosis.
Try कर.
Right or left?
Left side. say right because diaphragm is absent. Say lower look.
On lateral chest X-ray, what can you see abnormal?
Zoom. Can you zoom back? I tried to कर Snapchat मारला एक चैप्टर से. What can you see?
Where is the consultation?
Consultation.
You already figured out that it is in the
Lower lobe.
So where is the consultation?
It is near highest vertebrae.
How can you tell that this is consolidation or something else? There are more vertebrae design. So when you go down, the vertebra should be like Earth.
बहुत बेहतर तो होगा. Yes.
Here, when you go down, you can see it's whiter and not like Earth. So there is consolidation. So this is left lower lobe pneumonia consolidation. Now, advanced hip looks noisy hard, and the diaphragm for hidden
Pathology. Cardiomegaly. No? Heart size is
What if there is consolidation behind the heart and you cannot evaluate the heart size itself?
but on left side you can see on the lateral.
In frontal image. Can you see anything? Abnormal, except of the heart size.
It's on the left side diaphragm the blood.
Okay. It's not that much.
Yeah. Sharp.
About on lateral chest X-ray.
That border is lost on the hemidiaphragm border. Half.
Yeah.
Huh?
Yeah. This is the normal type.
That front opacity.
Right.
Can you zoom that near to the take out of that was that.
Right lower lobe consolidation. And it is only seen on lateral chest X-ray. Okay. Now atelectasis. Let's imagine. So far, we've imagined that the lung is the sponge, and we've filled it up with mainly with pus. So we have done pneumonia, right? And that's filling up the air spaces, the alveolar spaces in the lung, and now we're going to squeeze this sponge hole. So we're gonna cause some atelectasis and some collapse, and all of the air is going to come out of the lung. So actually atelectasis is somewhat a type of consolidation. And here we have the fifth case. What about this patient? What findings can you see? And how would and what would be your findings like this?
In the frontal view, that left side half border is not on. Then you can see air bronchopneumosis on the right, no?
Lung is too dark.
Can you see the left hand diaphragm or lateral separator? What else can you see?
Downside on the lateral chest. What is that black?
So similar to previous cases, here we have lost the visualization visualization of the left hemi diaphragm.
Mm-hmm.
But here, in comparison with previous cases, we can no longer see the outline of the descending aorta.
Mm-hmm.
Can you see the descending aorta? This is the
Aortic
aorta,
arch.
and then
Descending aorta. Yes, yes.
Here you cannot see the descending aorta, and we have gained here a second line. You see this one?
Mm-hmm. Yes.
One of them is the heart shoulder, heart border, and the other one is the atelectatic lobes border. So this is called sail sign, and actually this is the margin of the collapsed left lower lobe. What else? What is this? Why you cannot see the left costophonic angle? Look at it. There is meniscus sign
Mm-hmm.
when we see soil effusion. Okay, let's skip this one. And the second, the third part of the. We'll go through the whole effusions and then switch to the third part. So, do you remember what is the difference between nodule and mass?
Nodule size of difference.
Size. More than 3 centimeters are masses,
Mhm.
less than 3 centimeters are nodules.
Nodules.
So, any space occupying lesion, either solitary or multiple, and the differences between nodule and mass is their size. Pulmonary nodules are frequently encountered incidentally on chest CT scans. The role of the radiologist is to separate between benign and possibly malignant lesions and advise on follow-up imaging or additional invasive imaging techniques. The pulmonary nodules can be divided into solid lesions and subsolid lesions, which can be further subdivided into part solid and pure ground glass nodules. And nodules can be described as solitary or solitary pulmonary nodules. In evaluating a solitary pulmonary nodule, the critical question to be answered is whether the nodule is most likely benign or malignant. So the answer to the question of benign versus malignant will depend on many factors, including the availability of previous imaging studies, which can help greatly in establishing stability of the lesion over time. And also you should look for calcification, size, curve, shape, margin, and we'll discuss one by one. Now, benign pattern of calcification. When you see diffuse, central, laminated, or popcorn calcifications, those are benign patterns of calcifications. And these types of calcification are seen in granulomatous disease and hematomas. All other patterns of calcifications should not be regarded as sign of benignity. The exception to this rule is when patients are known to have a primary tumor. So, for instance, the diffuse calcification pattern can be seen in patients with osteosarcoma or chondrosarcoma, and similarly, the central popcorn pattern can be seen in patients with gastrointestinal tumors, and patients who previously had chemotherapy. In which diseases you would see pulmonary calcification of the lesion. Whenever you come across with a lesion on CT or X-ray, on CT scans, look up to the Fleischner guidelines to decide the follow-up of the patient, whether the patient needs to have follow-up CT scan or no. And when you see ground glass opacification, that is with a higher density than the surrounding tissue, but not obscuring underlying bronchoscopy structures. So the Fleischner Society pulmonary nodule recommendations pertain to the follow-up and management of the indeterminate non-calcified pulmonary nodules detected incidentally on CT scans and are published by the Fleischner Society. And the guideline does not apply to lung cancer screening, patients younger than 35 years old, or patients with a history of primary cancer or immunosuppression. So every time you come across with pulmonary nodules, just open the Fleischner guidelines and see what is your next step. So when you see ground glass lesion which is less than 6 millimeters, no follow-up is indicated. When it is equal or more than 6 millimeters, CT follow-up at 6 to 12 months to confirm persistence, then CT at 3 and 5 years old. So on. I will not go over this. How to measure nodules. In the Fleischner guidelines, nodule dimensions can be obtained using either 2D caliper measurements or 3D nodule volumetry. Manual 2D caliper measurements should be based on the average of the long and short axis diameters of the nodule, and in part solid, solid, subsolid nodules. Both the total nodule as well as the solid component dimensions should be measured separately as shown in this image. Then you should look at the growth and shape. Comparison with prior imaging studies is often the most useful procedure to determine the importance of the finding of the solitary pulmonary nodule, since stability over 2 years is highly associated with benign. Then you should look at the margins. Coronaradiated sign is highly associated with malignancy. Lobulated or scalloped margins have intermediate probability, and smooth margins are more likely benign unless metastatic in origin. So benign causes of solitary pulmonary nodules are granulomas, tuberculosis, and histoplasmosis. Usually produce calcified nodules less than 1 centimeter in size, although tuberculomas and histoplasmomas can reach up to 4 centimeters in size. So when calcified, they are clearly benign. Tuberculous granulomas are usually homogeneously calcified or diffusely calcified, and histoplasmomas may contain a central or target calcification or may have a laminated calcification, which is a diagnostic. Hamartomas will have popcorn type of calcification. Another uncommon benign lesions that can produce solitary pulmonary nodules include rheumatoid nodules, fungal diseases such as nocardiosis, arteriovenous malformations, and granulomatosis with polyangiitis, which is regular disease. Which one is benign? Is it solid? Is it subsolid? Or ground glass opacification? And what type of disease can be seen with this type of calcifications? granuloma, and the second one is cystic
That
granuloma
one's
with
central
central
one.
calcification. Do you remember which unit is the functional unit of the lung? Which lobule? Primary or secondary? Secondary.
Which is this
Lobule is the functional unit of the lung. And it is the smallest part that you can see on CT scans. You cannot see the primary pulmonary lobule because it is too small to visualize on CT scans. So we will talk about malignant nodules during the next PowerPoint presentation. Now let's again remember what is secondary pulmonary lobule. It's the basic anatomic unit of pulmonary structure and function, and it is the smallest lobule that is surrounded by connective tissue or septum, these yellow lines. And it measures about 1 to 2 centimeters and is made up of 5 to 15 pulmonary sinus that contain the alveoli for gas exchange. The secondary lobule is supplied by a small bronchial or terminal bronchial in the center and this black one, which is paralleled by the central lobular artery. And when it is colored blue, that is artery. Why it is artery?
Supply the
Because
alveolar.
they supply the
Alveolar.
blood, and then the exchange of the gas is performed here, and then the veins go to the heart, and the oxygenated blood is supplied to the other organ system. So then here we have also the lymphatics in the periphery. Now the central lobular artery, which is the blue oxygen poor blood, and the terminal bronchial run in the center. Lymphatics and veins, oxygen, which is oxygen-rich blood, run within the interlobular septum. So central lobular area is the central part of the secondary pulmonary lobule, and it is usually the site of disease that enter the lung through the airways. It can be either hypersensitivity, pneumonitis, respiratory bronchiolitis, central lobular emphysema, or so on. Now, patterns. What is the dominant pattern? Radicular, nodular, high attenuation. This is seen on CT scans, ground plus calcifications, consolidations, or low attenuation, emphysema, or cystic so on. So you should first of all recognize what is the dominant pattern. Where is it located within the secondary lobule, whether it is central lobular, paralymphatic, or random distribution. Is there an upper or versus lower zone, or central versus peripheral predominance? And are there additional findings such as pleural fluid, lymphadenopathy, traction, bronchiectasis, or so on? So you should look on the patterns. So let's understand how to differentiate the central lobular, paralymphatic, or random distribution. So the distribution of nodules shown on computed tomography is the most important factor in making the accurate diagnosis in the nodular pattern. In most cases, small nodules can be placed into one of 3 categories, such as paralymphatic, central lobular, or random distribution. And random refers to no preference for a specific location in the secondary lobule. Paralymphatic distribution in patients with a paralymphatic distribution, nodules are seen in relation to pleural surfaces, interlobular septa, or the bronchovascular interstitium. Nodules are almost always visible in a subpleural location, particularly in a relation to the fissures. these are the centrilobular distributed nodules. You can see this is the secondary pulmonary lobule, and in the center of the secondary pulmonary lobule, you can see nodules. Basically, pure lymphatic
Yes.
distribution. You can see
Interlobular
either
septum.
in the septa or fissure, along the
Fissure.
septa,
Mm.
fissure. And random is zero. Everywhere. So there is an algorithm to distinguish pyrolymphatic random and centrilobular nodules. Look for the presence of pleural nodules. These are often easiest to see along the fissures. If pleural nodules are absent or few in number, the distribution is likely centrilobular. If pleural nodules are visible, the pattern is either random, or also called binary, or pyrolymphatic. If there are pleural nodules and also nodules along the central bronchovascular interstitium and along interlobular septum, you are dealing with a pyrolymphatic distribution. Pyrolymphatic distribution, there may be typical fissural nodule or atypical, or also non-fissural nodule. So pyrolymphatic lung nodules follow pyrolymphatic channels and on imaging are typically subpleural, occur along fissures, perifissural nodules, interlobular septa and adjacent to the bronchovascular bundles. And sometimes the term reticulonodular is used as overlapping in differential diagnosis of pyrolymphatic nodules and the nodular septum thickening in the reticular pattern. So peripheral nodules are a separate entity and likely represent intrapulmonary lymph nodes. Morphologically, these are solid, homogeneous nodules with a smooth margin and are oval or rounded, lentiform or triangular in shape, and their location is within 15 millimeters of the fissure of the pleura. As you can see in the first diagram. The atypical peripheral nodules are not within the fissure or septa, but they can have one margin crossing the fissure. And the non-peripheral nodules, you can see that they are not strictly, they do not have clear margins. They might be speculated with margins, and also they would not be within the fissure or interseptal bit or in the interlobular septum. Where is the nodule?
Typical. That typical on the liver. Huh?
What is this?
Yes. Fissure.
Fissure. Very fissure.
Typical.
This one? Yeah.
Yes.
This one?
Mm-hmm.
Again.
No. That
Why?
one. That one. Because only one side is on the touch and the shape is not that one. Margins are not clear.
And this is sarcoidosis. Nodules are subpleural along fissures along interlobular septa and adjacent to the bronchovascular bundles. Can you see any centrilobular nodule?
That should be in that central.
But mostly the nodules are pyrolymphatic in distribution. Now centrilobular distribution. Central lobular nodules are seen in diseases that enter the lung through the airways, and the pathogens enter the central area of the secondary lobule via the terminal bronchiole. And the diseases are hypersensitivity pneumonitis, respiratory bronchiolitis in smokers, and so on. Now, we have also tree and bud pattern that is in sensory lobular nodules. The recognition of tree and bud is of value for narrowing the differential diagnosis. Tree and bud describes the appearance of an irregular and often nodular branching structure, most easily identified in the lung periphery, and it represents dilated and impacted central lobular bronchiole. So tree and bud almost always indicates the presence of endobronchial spread of infection, such as tuberculosis or any bacterial bronchopneumonia. Airway disease associated with infections such as cystic fibrosis, bronchiectasis. Less often, an airway disease associated with primarily with mucus retention, like allergic aspergillosis and asthma. What can you see here? What type of distribution is it? Solid, part solid bronchial obstruction, or something else? Let's start from this one.
Is it central lobular?
Central lobular. Okay. Is it solid, subsolid, or GGO?
Subsolid, I guess. Solid.
Can you see any solid part?
Solid part not subsolid.
This is GGO. About base case.
ट्रीचा आहे का ट्रीवर आहे का हां तो ट्रीवर पाठवला हां
And finally, the random distribution in miliary tuberculosis. The random distribution is the result of the hematogenous spread of the infection. Small random nodules are seen in hematogenous metastasis, miliary tuberculosis, and miliary fungal infections. Also in sarcoidosis, Langerhans histiocytosis in early nodular stage, and sarcoidosis usually has a pure lymphatic distribution. However, when it is very extensive and it spreads along the lymphatics in the bronchovascular bundle to the periphery of the lung and may reach the central lobular area too. So this may result in a combined paralymphatic central lobular distribution, which can stimulate the random pattern. And the last one. Next week we will have the midterms.
Okay.
That's why we're going so fast. We need to complete the chest X-ray and CT, and the midterm will include only chest and also basic radiology.
काय का होत का स्टॉप कर व्हिडिओ स्टॉप व्हिडिओ